Well, hello, and welcome to Mind Your Mouth podcast. I am Melissa Mugno, and I am so excited about today's episode. As I told all of you guys, I was going to bring on some of our favorite people and continue to have really authentic and vulnerable conversations. And today is going to be no different. Today, I have an amazing colleague and lately has become a very good friend, Dr. Kevin Boyd. And we are so excited to just and just kind of talk about all things that we're passionate about and a little bit of why we're doing the things that we're doing. So, Dr. Kevin, thank you so much for taking some time and joining us today.
I'm glad to be here.
We could have been.
When I heard you talk in San Francisco, that was my first vitamin Melissa. I mean, wow. It's turned into this. So I'm thrilled at the way things are going between you and me. So
Well,
yeah.
the feeling is absolutely 100% mutual. Of course, I saw you speak a while back, but a lot of the community and the people that kind of hang out and follow me have this really. It's been a really amazing these last 2 years. I've always been playing around in that ortho airway space for a long time, but when I got really vulnerable and decided to open up about my own journey and how much I struggled with mental health and my clenching and my grinding and just my whole that this Myo world secretly allowed me to truly become authentically myself. I've It's just been really beautiful, and I've kind of naturally been able to create a really special community. And so my goal and my mission with anybody that I've had on is that I just say to just be open and allow us to talk about. So I always kind of start the podcast off with a little bit of like, what is something that maybe a lot of the people that have heard you speak before don't know about you? Something about maybe your childhood or something that got you that kind of like is a driving force that makes you the pioneer that you are today.
Well, I'm gonna have to, and this is something, um, just part of my getting to know myself the longer I live, and reflecting, and something that really transformed the way I looked at adult caregivers who were bringing their children to me. Something that's sort of ubiquitous in child health care, um, is that we have most of our initial and ongoing contacts, at least for sub teenagers, uh, is with female adult caregivers. It's moms, and it's grandmas, and it's nannies, and it's big sisters, and it's just the way it is. And one day, and it might have been, oh gosh, maybe 12, 15 years ago, a woman, a mom, who stood about 4'11", and that's my mom's height. Uh, and she said, Dr. Kev, come over here a minute, please. So I went in the hallway. There's no one there, and she did this to me, and I hadn't had a 4'11" woman do that to me since I was maybe 12. And I was taller than my mom then. And she said, I just really want you to hear me on this. And she looked me right in the eye and she said, my kids love you. We love your work. We refer a lot of people here. All my friends' kids come here. But you know what you suck at, Dr. Kev? And I'm like, I'm not kidding you. I had a flashback because that's how my mother kept four boys in the 1960s. She didn't have beyond a high school education. She was married to Dr. Don Boyd. She was Mrs. Dr. Don Boyd, who, their marriage didn't work. And he, left home and just kind of deserted. Um, he had his own issues and love him dearly, rest in peace. But my mom had to raise four boys in the 60s without a college education or a job. And she put three of us into professional school, and became, very successful. My other brother tragically died 2 weeks before my wedding. My mom was a mess because she was happy to find out, I was finally getting married. I was 38, and it just sort of she said, "What you suck at." This is not my mom, but I wouldn't put that past her either. She probably said that to me too. Um, is managing my expectations. Like we thought this was going to be done, and you haven't. I can't manage my kids' expectations unless you're managing mine and my husband's. I manage his, and you didn't tell me, that this, if we didn't wear the retainer, the cross bite could come back. I can't even remember what it was, but, but it was my fault. It's always my fault. I own the place. I'm the doctor. So, I never say, oh no, your kid was irresponsible, didn't wear it. No, I never do that. Don't do that. Good advice. Okay. Um, and she just said, you just got to listen, especially to moms. She said that. And I really went into kind of I don't know, a mini depression over that. It took me a while to get over it even. And then I just started to realize the impact. So what I'd like people to know is, about me, or anyone who knows me and gets to know me, my patients or you as a friend, you're going to find out I was raised by a single mom who was the unsinkable Molly Brown. She went out and got herself trained and ended up working for a big corporation, started making good money. And, like I said, the rest is
Yeah.
history. I just,
So, that's a really amazing. I love that story, and you shared that a little bit when we were at dinner,
yeah, yeah.
and in Denver. And the one thing that I think, if I've had any movement in this space, it's been I really try to have this art of communication, right? I care a lot about making things digestible, because this is an elephant, this world that we're in, managing airway and expectation and pioneers. And it can be hard. To digest it sometimes. And so, recognizing and listening to you say, hey, one of the things I have to do is be able to set proper expectations as well as proper limitations, so that I can manage everybody, so that everybody feels like they're on the same page, I think is something that a lot of practitioners struggle with, because they're trying to, run these practices, run their staff, all of these, kind of societal expectations that we're supposed to have. And one of the number one things docs will say to me from a consulting side is, they'll say, Melissa, I 100% believe in it. I believe in what you guys are talking about, but I just don't know how to make it successful. And I believe, and I think you would agree a little bit on this, it's because they really struggle to communicate on it, or they treat it like a little bit of a redheaded stepchild, or they think it's not really present. And between, for me, when I realize is that we're always dealing with airway issues. And I know your main passion is kiddos. You said to me, I care about these little kids, Melissa.
Mm.
And tell us, a little bit about why you're so passionate about this age group. Why does it, like, just, I mean, I know the answer. I know a fair amount of people do, but just remind us, why do you think this younger age, before 6, right? Right? Are we still even younger? Even younger, correct?
How about in utero?
In
Like
utero, yeah,
we're looking at fetuses now. So go
yeah.
figure.
So
Uh,
for some people that have no clue exactly who we are, what's the mission? Why do we got to fix it early, Dr. Kev?
I think we could start out, because I read your questions and I'm like, think about this and what is it you'd like to change, and you know there's a couple of things that I really am determined to help bring about meaningful change to the system.
Okay.
Um, this morning on the Doc podcast, I don't know if you've ever
Oh
watched that
yeah,
with Mike
absolutely.
DeLuca.
Love Mike.
Well, this morning he had this woman, Lambert, um,
Yes.
and you know what I really liked about what she said is, it's not like we need to get in debates with people and I'm right and you're wrong. We need to get in meaningful discourse exchange. Like, yeah, we disagree, but let's talk about it. And the system needs to change. And I thought that really resonated with me. I want the curriculum in orthodontics and pediatric dentistry and pre-doctoral dental school and hygiene. I want all those curriculums to change. And they haven't really been modified much in the last 50 years. They just haven't. So that's one thing, is that, the system needs to change. I don't really need to change individual people, even though that happens sometimes when you're not trying to. Um, so I really think that is probably the the most important thing that has to happen. And why I got this way is because I was in the right place at the right time. I'm on staff at one of the largest tertiary care children's hospitals in the world. It's in Illinois for sure. It used to be called Children's Memorial Hospital, and now it's Lurie Children's. Well, the head of sleep medicine, Stephen Sheldon, is a pediatrician and a pediatric neurologist, and he one day called me up on the phone and he said, I understand you're doing Bill Hang's BioBlock, and I need someone on my team to do that, because he had learned about it. And he selected me out of, I don't know how he found out about it even. And that changed me. And I started publishing, and he started referring patients to me that, that maybe they needed their tonsils out, but the parents didn't want to do it. And this is before the Stanford study that showed that transverse expansion can actually normalize, lymph tissue, adenoids, and tonsils, help the jaw come forward, all that. I didn't know any of that. I just knew that I was very comfortable doing early orthodontic dentofacial orthopedic treatment in the primary dentition. And I knew that, a class 2 always is a class 2. It never changed. It can't get better. I think, and that, malocclusion is a disease. I want that to go away. People don't think that the orthodontic industry does not want you to think it's a disease. They call it a dentofacial developmental disorder. That's a disease.
Well, that's a really important
Yeah,
conversation right there. So many people will say, no, it's not. And how, a question I get asked by a lot of the therapists will be, well, Melissa, I don't want to argue with people, but how do I create them to see or feel or see the things that I'm seeing? Um, and I always say it is a bit of a passion, right? You kind of have to believe it and have conviction in it. But that comment, when you say that, there is a lot of science behind that, is there not? I mean, I
yeah,
know you're
absolutely, absolutely. But and you can send people papers, and they don't want to see it. They don't want to know, and they'll say, "Oh, show me a randomized prospective trial." Well, that'll happen sometime, but not yet. Right now, we work with the best available evidence, and it's good evidence. It's sound evidence, but it's still a hypothesis that we're gaining support for. Everything I'm saying is a hypothesis. You know, I mean, the theory of gravity started out as a hypothesis. So well, E equals MC squared. Do you think Einstein did a
yeah,
prospective randomized trial? Do you know how he discovered E equals MC squared? He was like,
no,
I
tell
think,
us.
21 years old, riding his bike in the rain in the late 1800s, turning on his headlight and imagining himself pedaling fast enough to overtake the light beam and turning into energy, going from mass to energy. That's what E equals MC squared means, when mass becomes energy. And it was an imaginary thought experiment. Uh, so, I just, I think constructive discourse. And another thing that's happened recently, and I don't know if I told you about this, is
Mm.
I was getting very frustrated with people that were like, God, Kevin's unethical. He's treating them before 6, and he's using up the lifetime orthodontic benefit. And that's why I'm unethical, because I use up the lifetime orthodontic benefit. And I was sort of just dumping on Steve Carsonson. He's like my shrink. And
Steve is
Steve,
amazing.
oh, he is. And he processed it, and he said, you know what, Kev, here's a book you should read. It's by somebody named Mel Robbins. It's called The Let Them
Let it,
Theory.
yeah, yeah, let
Yeah,
it,
okay.
what is it? Let it be, or let it go, or let them have it, or whatever, right?
Just,
Let
just
them.
let them. Just let them. And because Kevin, you need to focus your energy on the people that understand what you do and want this, to improve their family and child's lives, and just let them. And he goes, but I will, because I identify with what you're saying. While we are letting them, many children will go unserved. Many children will go unserved. Steve, Carsonson, that also was transformative to me. That
Mhm.
many children are going unserved, Melissa. So this is why your platform, what you're doing here, reaching people, what Mike DeLuke did this morning, with um, on that wonderful podcast. I just, it's reaching people,
It
and
is.
people are becoming curious. And the book Breath, I mean, he's gotten more people interested in
Oh,
this. I,
100%. And what I've noticed about Dr. DeLuke, I think we both have been on his podcast. I was at dinner the other night, not that long ago, with my husband, and I live down in this town, and I've been here about 3.5 years, and it's an interesting concept here. So I'm in Louisiana, and it's an interesting place, I find, because the academia here is really, I don't know, maybe you probably would know more on it, but I lived in a couple states, but here LSU has a dental school and a medical school. And people in Louisiana really, like, they love their culture, right? So every single dentist in this town that I'm in, I think there's about 85 and about 15 orthodontists. All of them all graduated LSU. It's very unique. They all have the same academia concept. So for them to change their mindset, it's almost like going against their religion. Like, I don't mean that to be, rude, and I don't want to upset anybody, but I had never seen I've never lived somewhere where the college is almost idolized like a religion, right? And so for these docs to change to go against the grain or to go against it, I mean, I think it's almost sacrilegious down here, right? And when I first came down, there was one doc who was pushing the envelope and was really trying to bring this airway concept. Long story short, the orthodontist wanted no part of it. Well, I'm sitting at dinner last week, and this particular orthodontist sees me, and she pulls me over. She goes, "Hi, Melissa," and I said, "Hey," and she goes, I heard you on the doc podcast."
Yeah.
I said, like, "Oh," she's like, "We do really like Dr. DeLuke." I was like,
Oh, good.
"Oh, okay, fine."
we.
But
That's
it's
so funny. Yeah.
interesting that this concept in certain areas, it feels like it's like as if we're treating some crazy. I go, they know it's true. They know we're not wrong. It's like, but it's like they can't admit it. It's a very interesting concept, but the one area I have found that they will not push back on me, and this is what I tend to tell a lot of people, is find your niche in the space, right? Like, have a connective story, what drives you. And when I did that first presentation where I put up a little picture of Melissa at 3 years old with my little jaw forward, and then I proceed to walk down my mental health journey where I said, my mom said I had my days and nights mixed up. She said I was a picky eater and that I was just stubborn. And then when I was in school, I struggled to wake up in the morning. And then they thought that I just didn't care. And then I was struggling with, retaining information. So then, they put me on Adderall. I'm clenching, I'm grinding, but I never needed braces. But what you can see is how mid deficient I was. Wasn't until later on I got a CBCT scan. I'm sucking air out of a cocktail straw, grinding my teeth down to nothing. And then all of a sudden in my 30s, I'm on more antidepressants and Adderall, and I'm still depressed. I don't know why. I'm anxiety, overthinking, all of these aspects. And here I was practicing myo, and until I really started to take over my own health and really talk about it. And when I opened it up that way and I said, listen, I think there's a correlation and a connection between the sleep disordered breathing, ADD, ADHD, and I'm telling you, we can see it in these kiddos at 2 and at 3. I said, don't worry about Melissa at 40, but fix Melissa at 3 so that I don't have, so you don't have to go down this journey. That's when they all go, well, they can't argue with me because it's my own story. And I'm showing my teeth and I'm showing me being 60 pounds overweight. Then I'm skinny, my skin, digestive system. And then I realized that there's like a little window if you start talking, because there's so many parents that don't know how to handle their kiddos with this behavioral stuff. And that's just something I become really passionate about. And I'm just curious what your take is on that connection with the behavioral and the airway and the dentition and these little kids. And I think some of the listeners would love to hear your view on that.
Well, it started out, I mean, I was very sort of, I don't know, liberal in my training at the University of Iowa. We were really aggressive with orthodontics. We would actually expand kids without cross bites, but never really before the age of 7. We didn't go that far. And when I graduated, I just went to hell. It'll work on a 7-year old. It'll work on a 6-year old. And I maybe a few 5-year olds, but I really didn't venture under 5. But people were, this is like 25 years ago. And I remember the first time it happened, a mom goes, when you fixed, when you expanded his upper jaw, he stopped bedwetting. And I was thinking to myself, okay, if you say so, but, and I didn't keep any mind to it or anything. And then it was maybe a couple years later, somebody else said it. Maybe there is something to this. And I think I was sort of being inadvertently, subconsciously being led down this path by just listening, hearing things and listening. And then it's when Steve Sheldon in a lecture, he said, he opened it up with ADD does not exist as a psychiatric disorder, although it's listed that way. It is a result of poor sleep hygiene. That's a term I'd never heard. Sleep hygiene. Hygiene means health. It doesn't mean clean. Cleanliness is a component of health. That they call it hygiene. And he was so certain he was correct on that. And that so often kids, behavior problems would clear up when they could sleep better, and they could sleep better when their jaws were wider and they could nose breathe. It wasn't really one sudden thing. It's just something that was gradually happening and seeing. And then I found that, in terms of within the 3 to 5 year old range, I was one of the few people, not only in Chicago doing it, but in the world. I mean, and now there's so many people doing it. I mean, it's wonderful. It's getting more people every day. I don't mean to run on here, but it just,
No. We are run away.
says run away, run away. There's that was Post Malone's song. What's that?
You're very hip. You're into it.
Anyway, I get an email, a really long email yesterday from a dentist from Atlanta, and said I got these twin 3-year-olds about to be 4, and it listed all the symptoms. And I've taken your online course through Airway Health Solutions, and I've heard you lecture on myomunchie and all these things, but I just can't take the plunge. I'm afraid I'm going to hurt my own kids, and I definitely wouldn't treat another kid, but can you help me? Can you mentor me? And I'm just like, how many other people who might, listen to one of us or both of us lecture? Incidentally, you and I have to lecture together. I mean, we just have to do an all-day workshop. I think we've talked about it.
Yes.
But how many other people are just not, they don't want to take the plunge? What can we do to help them, Melissa? Like, what do you say to somebody, even like a myofunctional therapist who doesn't want to see a 3-year-old?
Well, I think one of the big things is that I have found, in the movement of anything is just trying to make, again, like I was saying a little bit before, just trying to make things a little bit more digestible. People live in fear, right? And everybody's so fearful. And for me, fear is just scared, anxious, trying to control the future. That to me is just shows how like truly the biggest epidemic is this anxiety. Everybody's so anxious, so fearful of offending and upsetting everybody. But the truth comes down to, you need to be able to educate. And one of the easiest things I say to people is like, you're not going to hurt anybody by starting to have conversations and address soft tissue dysfunction. I think that's where myofunctional therapy and soft tissue at these younger ages, if you can start to show people how to highlight the dysfunction and show them it's already there. There's nothing to be scared here. Like worst case scenario, you're already in worst case scenario. Like everything's uphill from here, right?
Yeah.
So one of the things I joke with dentists all the time is that, do you remember? I tell you, you've been a dentist for a while. How long do you remember practicing without doing sealants? Like
You
sealants
know,
for teeth, right? When did sealants?
sealants actually, I remember I was at Loyola Dental School for my interview in 1982 when I was applying. And I remember there was a dental student that scratched something on a wall, and it was about sealants and Pitt and Fisher sealants. So that's the first time I'd even heard of it. And I think it was something that insurance wasn't paying for it. I think when I got out of dental school in 1986 is when and then pedo, and we were doing them on 6-year molars, but never primary molar. I got written up when I was teaching at the University of Michigan.
Uh-huh.
Um, a lot of kids were on public assistance, and coming in with all these caries, and there'd be a kid in the same family that maybe was showing signs. But I said, what you do is you open up the pits on all the baby teeth and seal them. And you know why they wrote me up?
Why?
Because public aid won't pay for it.
Yeah.
And I didn't care. That these students are here to learn, and I'm here to teach, and this is a valuable service. And they wrote me up. I was disciplined for instructing my third-year dental students to put sealants, protective sealants, after bite wings, no interproximal decay, on primary molars. It was just like I had committed a mortal sin. So
I
anyway,
think that, look, I always try to go back in history. The one thing I've realized is everything we're trying to do, somebody in history has also done something, some type of pioneer and change thing. So I always try to find a correlation and a connection. And I think you walk into a pediatric dental office now or a dentist, they'll sell sealants all day, every day, never think twice about it. And I always
yeah,
say there was a time that sealants were not accepted, like were not something we did freely. It wasn't like it was a no-brainer. You had to educate and you had to explain. People, you'll still hear people say, oh, they don't do anything. They're an insurance policy. They don't guarantee anything, but they will help you possibly not end up in a situation that could be worse. And I think if we can spend time educating just by looking at myofunctional disorders, acknowledging that the muscles affect the bones, which is anatomy, right? I mean, pretty basic anatomy there, and recognize that some discussion and education that the tongue matters and the lips and the way we breathe, you can almost think of this myo or early screening as the sealant of malocclusion or the sealant of ortho, something along those lines, phase 0. There's got to be a way of helping doctors feel like they can do something. They don't have to do everything. And I think it doesn't have to be all or nothing. And that's been one of my kind of missions these last couple years. And I don't want to jump ahead. I know we're going to talk about some future projects, but one of the things we ended up connecting on was one of the reasons I got involved with Munchie. I was
yeah,
looking for something. To be honest, I was tired of arguing. I was doing these doctors, offices, trying to help them build their systems, and they would have staff turnover. They didn't have great practice, all these things that were kind of outside their control. And I was like, I'm just looking for something to show the parents what I'm seeing or show the doctor what I'm seeing. And I started talking about highlighting the dysfunction. You don't have to believe me. Let me just show you.
hmm
And I was looking for tools that was something that mom could take home, walk out the door with, so it didn't feel like we were. And then all of a sudden, use a video, because everybody has, the patience of a gnat these days. 3 seconds, pop something in the kid's mouth, and all of a sudden you see the eyes go up or the nostrils flare or their face looks crooked. And I say, see what happens when your kid tries to go into a perfect malocclusion, they look weird because that's not how they're functioning. And then all of a sudden the parents started looking. I think we need more things like that to, I hate to say it, but I think people are so impatient. They don't believe it. You got to prove everything to everybody. So maybe it's our jobs to continue to highlight it and showcase it better by taking really complex concepts and bringing them down to more, I hate to say it, I guess Instagram quick posts, because that's how they all want to learn these days. I
Well,
That's
yeah,
how I kind
you got to get their attention, and that was really interesting what you just said. When we talk later about what you're going to do with the Munchie Project, I would like you to really demonstrate what you just said, how the parents really notice when the
yeah,
kids.
well,
Yeah, like that's really cool. I mean, I
do
will
we,
use that.
I mean, since I brought it up a little bit, I don't want to leave the listeners hanging. Can you share, or what you're allowed to share, a little bit about what you are working on with Munchie, and what Dr. Mary and Iggy and everybody's been working hard to help you guys cultivate? It's really exciting stuff. I'm sure everybody's interested to know what they're allowed to know.
Well, Mary Burke is the daughter of Kevin Burke, who invented in Australia the Mayo Munchie. And she and I were just sitting at a meeting, and we just cooked up this idea to do a randomized trial,
Hmm.
prospective. It's not going to be blinded. Obviously, you can't do that with that, but there is randomization. It's going to be, and we've got a biostatistician, and she's fund. Mayo Munchie is funding it, but there will be absolutely no conflict of interest because Mary wants, I will help organize this, but the results are going to be reported, whether they're favorable for the Munchie or not. And no, that's what she wants. And she's a doctor, she's a chiropractor, and a myofunctional therapist. And her son, her nephew, Ignatius Iggy, is a third year, maybe fourth year medical student now. And he's actually the project manager from Australia, and we have Dan Berland, who's a physician at the University of Michigan, who is a clinical scientist and made sure, and Jerry Simmons now is advising on it. So it's a really well designed study. Oh my gosh. And you're going to be advising on it. Just so glad that Mary approved to recruit you into it as an advisor. And um, so we got a great team, and we have four groups. One is a control because there is no standard of care for
Hmm.
myofunctional therapy. We
Yep.
can withhold one of the interventions. You can't withhold a therapeutic intervention for the purposes of creating a control group when you're working with humans. That's because of World War II and the war crimes of the Nazis, were doing cruel medical experiments, and it's unethical. But something very short term, and there is no standard of care for myomunchie, we can delay giving them the therapy because all the children in the study will be diagnosed with at least two diagnosable orofacial myofunctional disorders. They will have maxillary transverse deficiency with or without a crossbite. They'll be between the ages of 3 and 5 and medically healthy. And those, so that's just a real basic, and that's what I can talk about. And it's going to run for 6 months, or less. It's not a real long, it's a pilot study,
Hmm.
uh, which will hopefully lead to a larger um, prospective randomized trial. So
Which is
that's what we're
really
doing.
exciting in general for, one, I'd like just for myofunctional therapy, but also the power of tools, right? And I think tools are really powerful if given in the right direction, and things. And I use the example a lot of, I go back in time, every time anyone asks me, what do you do or what is it? And I'm always like, listen, I'm just like a personal trainer of the mouth. That's it. Like, I just try to guide and educate. And I go back to this concept of like, I've been on a physical journey with my family and myself for decades. And I'm the queen of like, I think I told you this story at lunch. My mother, as we speak about moms, was very fit, and she would run and she would do everything, and she looked like very, very feasible, good tone and structure. And I was telling you about the ab roller. And I remember my mom used to do Jane Fonda and all this stuff. And I remember she bought, she was a QVC junkie and she bought this ab roller. And I remember she was working out with this thing. And it was the first time I really noticed my mom didn't look really sleek when she was exercising. She looked a little funky, like her face was red. And I remember her shoulders looking all off, thinking like, huh, I wonder why my mom can't use that device. But what it did was it was highlighting that the mid of my mom's abs were not very defined, right? She had a lot of other muscles that were strong, but that tool highlighted and genuinely put the direct force where it needed to be. And I remember she worked that ab roller for 8 to 12 weeks. Afterwards, you could see my mom's abs looked very different. She did go on to do other exercises and other programs, but using that tool showed her that she ultimately needed to put more time and resources into those muscle groups. And I think
Yeah.
tools can do that from all types of parts of our body. That's why we have gyms filled of machines.
Yeah.
It's not like you can't, lift water jugs and stuff, but every day a company's making out a new dumbbell. So I think these tools are so pivotal in helping us continue to mainstream and really make it easier and help people to want to claim back their own oral function and facial fitness and be able to breathe easier. Most people don't realize it, how powerful all the muscles are of the mouth. I I don't know what your thoughts are on that, but I always think that the tongue is very similar to the abs. It has all these intricate muscles. You got to do weird things to work them out. I think about side crunches. I think about tongue movements. So, yeah, I think if your tongue isn't in shape, you're going to compensate just like if your stomach isn't in shape. You're going to use your lower back. You're going to overuse your hips, your knees. I think the tongue is the same thing. If you don't have strength in the tongue and the lips, you're going to really use a lot of other heavy muscles to pick up the weakness.
Well, what I usually introduce to people when, I talk a lot about our ancestors, and malocclusion is like relatively a brand new disease in humans. It's not been around that long, but I say it starts in utero, and there's a lot of things. I'm speaking at the ADA in a few weeks with Robert Lustig. We have a whole afternoon together. He's doing two talks, I'm doing one, and then we're having a Q&A. And um, my topic is nutrition, food choices
Mhm.
as treatment. And my background, I have a master's in, I'm actually educationally qualified to be a dietitian, but I went to dental school when I finished my master's in nutrition and dietetics. Um, and I've found it very useful within the realm of myofunctional therapy, to actually have this credential as a nutritionist. Um, and one of the things I say is in utero, the tongue is building a nest for itself to live in for the rest of its life. It's chewing
Mhm.
and swallowing amniotic fluid. You know this, but most people
Most
don't
people
know
don't.
that. And then, throughout human history, if a child didn't get immediately on the breast and then wasn't eating everything that an adult was eating, certainly by 18 months of age, and even sooner sometimes, and sometimes later, but they had to, or the child would not survive childhood. It just wouldn't happen. So one of the hypotheses we've come up with is that the reason we don't see any malocclusion at any age of any fossil, any ancient skeleton, any cranium, skull, zero really, maybe a little dental crowding in Egyptian mummies, but that because they were wealthy, and rich people didn't. They had their food pre-masticated, and their whole lives they didn't have the stress of chewing. But even those mummies had erupted wisdom teeth. Well, the reason is if you didn't have a foundation for a perfect craniofacial respiratory complex, okay, through, by age 3, you're a goner. you would
Mm.
not get out of childhood and you wouldn't live to reproduce and become an ancestor. Okay, so that's a bit complicated, but really what that boils down to is food choices, which is, my talk,
Yeah.
food choices as treatment. Well, there's no malocclusion because the choices were minimal throughout human history. You and we were in a constant state of semi-starvation. There's nothing wrong. You've heard of the Okinawa diet or the blue zones.
Yeah. Yeah,
These
absolutely.
people, they stop eating when they're 80% full. They're underfed and they're always a little bit hungry. And there's nothing wrong with that. It's a good kind of stress. Not all stress is bad. You use the term stress. That's another thing I'd like to see go away is sympathetic overdrive. Do you know what that means? We have an imbalance. We have an imbalance of reactive oxygen species, meaning free radicals, and antioxidants, either endogenous like glutathione, it's a hormone, or the foods we eat, antioxidants, or supplements that we take. I'm not advocating supplements. I'm just saying when we're out of oxidative balance, it's called oxidative stress. I encourage everybody listening to this, especially you. You hit oxidative stress in any disease that you can think of, and you will find at least 10 papers. And this is something that's been left out of dental education, myoeducation. We need to understand oxidative stress because you know what it leads to? It
Wow.
leads to cellular senescence. That's where the term senile comes from. And do you know what precedes Alzheimer's disease? Accumulated senescent cells. They're metabolically active cells that secrete bad stuff. And they get cleared out by the immune system when you're a little kid. But if you got too much of them too early, you're going to age faster. The rate of aging is faster. So
Well, one of
that's another thing.
well, I have so just on that topic, when I
Yeah.
was, I guess maybe it's been almost like nine, no, I guess maybe 15 years now. My grandfather, very close to him, really smart guy, didn't have major health issues, but he called me. I'll never forget the day. He went to the dentist. Dentist told him he wanted to do all on fours, right? Because he was happy, he's in his 80s, late 80s. And I remember he called me and he said, "Oh, this doctor, wants to take my money." And I said, "No, Grandpa," I said, "please don't do dentures." I knew enough. I said, "Don't do dentures." I go, "Pay the money. Who cares? We don't need it." And he said, "No, no, no." And I'll never forget, he didn't listen. He ended up getting dentures. And Kevin, his health and his cognitive and dementia, I mean, it was like rapid fire. His diet went to crap. He started eating, I'll never forget, the only thing he wanted to eat was soft chocolate chip chewy cookies. He never wanted to eat anything. And I'm telling you, I never saw anything happen. It was like putting gasoline on a fire, and we couldn't maintain it anymore. And I always said, I'm telling you, he took his teeth out all the time. His quality of life went down, and very quickly afterwards, we lost him. And it was a terrible ending. And I kept thinking, there's something about the vertical of his bite closing so much, right? He had his lower jaw falling back. His air quality went terrible. His just everything. This was a guy that lived really well. And one of the things I struggle with the most, and I work really hard on now, is my short-term memory. I'll forget people's names, and I know it's from the year. And I mean, it brings tears to my eyes. I actually had to tell people, like, I struggled for decades with sleep disordered breathing. I didn't have proper things, and one of the biggest side effects is the short-term memory. I have to do so many breathing exercises. So just to correlate what you're saying, I don't think people
Yeah.
talk about this enough.
Well, it's tough. And listen to me, like Melissa, yeah, my life's about to change after this ADA thing because I've already introduced it in my practice. It's radical enough that I talk about body mass index. I mean, I can do it. I'm a nutritionist, and you get a height and weight, and unhealthy weight causes oxidative stress. There's something called ACE scores, adverse childhood experiences, and these are really awful things. Kids growing up in Gaza right now, or in Ukraine. These kids, there's hell to pay for what's happening to these children because they're forming senescent cells. They're under such stress, and it comes back when they're older, and they're going to age faster. All these kids, and they're going to get age-related diseases that senior citizens get. They're going to be getting them in their 40s and 30s, and it's just ACE scores, ACE scores. Google it. Those are really awful things. Yeah, adverse childhood experience. But there's another hypothesis I'm going to pose is that not as tragic as ACE, situations like child abuse and just awful things that happen to kids. But subtle things like sleep disorder, breathing, intermittent hypoxia. I really could say, Melissa, that what you are hypothesizing about yourself is maybe your
Mm-hmm.
short-term memory is bad because you suffered things earlier, maybe early in childhood when maybe you were suffering intermittent hypoxia. I don't
I
know, but I
no,
know we have to help these kids have
well, no.
optimal. Yeah,
I think
it's
this is a really great topic for people to hear, and I'm very open about it, and that's where I'm different. It's no blame. I don't blame anyone, but yes, I had I had a pretty traumatic childhood. I had some really severe traumas from the ages of 5.5 to 6. And then they proceeded in different ways, a lot of environmental changes, a lot of, just changes in and out of different people coming into my life. From, most of that early child, it didn't really calm down until I was maybe about 14. So those early years were really, really stressful. And I've had to do a lot of work on overcoming those traumas, because half of the time was, my poor little body, never mind, just because of the environment, I would kind of clench and hold myself together like this and would try to adapt to new environments. So I built these defense mechanisms, and I've done a lot of different therapies. I openly talk on the podcast about I the real truth is, people will say, well, Melissa, what was the change in your journey? How did you go, 10 years ago to today? It's not just myofunctional therapy or my new appliance or anything. It's because I also had to address with the stress factors from the childhood, right? I went down to Costa Rica. I sat down with some plant medicine, and I was able to really process. And once I started to relieve some of those environmental stresses and get past it, all of a sudden I was able to kind of adapt, and I wasn't having so many episodes in my adult life, right? And then the big thing was losing the weight. I was also like, it was like mind, body, and soul, right? And so my short-term memory is better, but last year I broke down. I was hysterical crying because I was in this retreat, and this lady thought I was being rude because I couldn't remember her name, right? Like, and I was so
yeah,
embarrassed. So I was modifying it. And I think a
yeah.
lot of people don't want to talk about how, I think a lot of people struggle with it. I think a lot of people have issues.
What one of the things that I am also going to introduce, and I've done it in a few of my past lectures, and I'm sure I probably, because I've shared things with you when they're still like in my not fully formed ideas, but you bring that out in me. Um, Gloria Najadas is another one who does that.
Ah,
You know
so
her.
good.
She
Ah, it's
I get
amazing.
talking to her, and all of a sudden I just start. Well, anyway, something I learned during this deep dive, and this is also important for everybody listening to this, especially you, is that there's one thing that I cannot believe that I only found this out less than a year ago, and that is what every child diagnosed with Down syndrome will be diagnosable with between the ages of 35 and 40. Do you know what it is?
What?
100% of kids with three 21st chromosomes, trisomy 21, will be diagnosable with enough amyloid beta plaques in their brain to have Alzheimer's disease. They're all going to have Alzheimer's. Kids never used to live that long with Down syndrome now, and they don't all have dementia right away. Okay, so here's what I'm introducing at the ADA. Every child born, has at least two 21st chromosomes. Do you know why kids with Down syndrome get beta amyloid plaques in their brain at like starting in utero?
Why?
Are you ready?
Yeah.
because amyloid precursor protein, the allele is coded for on the 21st chromosome. They have three sources of it. Okay, so they're producing,
Wow.
and you know what? Do you know what stimulates it? And again, it's not 100% like this will always do this, but it has to do with oxidative stress. These children, they have trouble breathing. Often they're overweight. You know, so I'm just saying we have to treat every child that has oxidative stress from whatever reason, whether it's their home environment, whether it's they're overweight, if they're not a healthy weight, if they're eating unhealthy, if they have an infection, but intermittent hypoxia during wakefulness and sleep. This is a stressor. It's an oxidative stressor. It doesn't qualify as an ACE, adverse childhood experience. Those things are just, but it does the same thing at the molecular level. Stress, we use that term stress really we apply it to everything. At the molecular level, it means that cells stop dividing. Mitotic cells have a limit. It's called the Hayflick limit. I'm telling you way more than you want to know here. But this was discovered in the
No, no,
60s.
please.
All the cells in your blood vessels and fibroblasts and your immune system, all cells have the ability to divide in two and make daughter cells and divide again and divide again and divide again. But the limit was discovered by Dr. Hayflick is about 65. Okay. And it's a protective mechanism against cancer, is that if a cell starts dividing too quickly on its
Hmm.
way to becoming immortal,
Yeah.
cancer cells are immortal, they never die. Well, our body will shut it off before it reaches the Hayflick limit. And then that cell becomes senescent. And if it's allowed to hang around, like if the immune system doesn't come and scavenge it and get rid of it, they accumulate and they start secreting bad things. So, not all senescent cells, it's not necessarily always a bad thing because it helps in wound healing. It's looking for cancer cells that they're dividing rapidly. But in a little kid who's trying to wants to get good, restful, restorative sleep, what
Hmm.
does that mean, right?
Yeah.
That's what it means. Not producing too many senescent cells and allowing the immune system to clean them up so they don't accumulate and they don't age as fast.
So
Okay?
just for the person that doesn't know exactly what we're talking about, what would that look
Yes.
like if you were to walk into your kid's bedroom? Like just to give them a little bit of a visual, right? So what should we be seeing when a child's sleeping?
You remember three initials. This is a three-letter acronym. And I remember it's summertime, we like ice cream, Dairy Queen Sunday. DQS. Kids should be dry. They should not sweat. They should not sweat. They should not drool. They should not be thirsty. They should not wet their bed after potty training. They should not want to get up to go to the bathroom after potty training. That's called polyuria. The other one's nocturnal enuresis. So they should be dry. They should be quiet. You shouldn't hear them breathe. You shouldn't hear them talk. You shouldn't hear them grind. You shouldn't hear them rustling around and walking in their sleep, talking in their sleep. And they should be still. They should change position a couple of times a night. They shouldn't be banging their head on the pillow. They shouldn't be, again, moving like a soccer game was played. You look at their sheets in the morning and they're just all over the place. So kids should be dry, quiet, and still. And that's the whole pediatric sleep questionnaire right there. All 24 questions or whatever it is.
Yeah.
They break down into that. You should see dark circles under their eyes. They should be able to wake themselves up in the morning. Um, they should be in bed and fall asleep within 20 to 30 minutes at the longest. That's called sleep latency. Um, those are just things that lay people can do. We tell parents to do that.
To work through
So,
that.
yeah.
And now that sounds great in theory. It's not always easy achievable. There's a lot of kids that are definitely not doing DQS, that's for sure, right? Or yeah, right.
No,
They
no,
are
right.
they're all over it. And with that, just to kind of keep things That's another thing is a lot of these parents, I think they say that it's normal, right? People say, oh, I hear it all the time. The therapist will tell me, well, they say it's normal. Kids will grow out of it. So I just want to talk a little bit about myths. I know a lot of us
Yeah.
know it, but some of the people don't know. What would you say are some of the common, like, big myths out there that people just automatically say, oh, it's common, it's normal?
Well, right away, the normal means average. The norms. I mean, normal just means average. It doesn't mean optimal for health. It used to, the structure that all humans had in order to survive childhood up until, maybe 400 or 500 years ago, normal was also optimal for health. It was the average, the phenotype of the craniofacial respiratory complex of all humans that have ever, survived childhood. It had normal meant optimal for health, optimal for survival and thriving, and ability to pass on your genes. That's called evolutionary fitness. So, so I using the term normal is just you really have to qualify it. It just means when somebody says, "Well, it's normal." I mean, I learned about bruxism, and I went to the one of the best pedio residencies in the country, if not the world, at Iowa back then. And our director, I said, "What about this grinding, Dr. Fall?" And he said, "Dr. Boyd," he talked kind of like that, "Dr. Boyd, um, you know one thing for certain. Have you ever seen the movie E.T.?" And I said, "Yeah." And he goes, "Well, you know that your patient here is not an alien because all kids do it. All earthlings do this." And that's what he said. It's a ubiquitous trait,
And
grinding.
all
He
earthly
did,
good.
yeah, yeah. All Earthling kids do it. I mean, or the vast majority. I just and he compared it to ET. That's how I remember that he said that because there was no relationship. We didn't learn about airway. I learned cephalometrics and growth and development from Samir Bashara, famous orthodontist, academic. He's the one who discovered the distal step. Class two deciduous always becomes a skeletal class two, but he didn't know about the airway thing and he wasn't saying we should fix it. That the inner canine width after about 6 years old, you don't get appreciative change there. So if on a Panorex, if the distal of the unerupted lateral and the mesial of the unerupted first bicuspid are in close proximity or touching, that canine, that maxillary canine at 12 will never erupt optimally. And that's a proxy for a myofunctional disorder. There's no tongue space. That's why I take Panorexes on 3-year-olds and 4-year-olds. And it's less radiation, than 2 days of sunshine.
I love this is a really important topic. And I think one thing I get, a lot of from questions is so many dentists are anti early expansion. And, a lot of these therapists will say to me, Melissa, how do I even hold this conversation? I'm seeing patients or even parents. I had 5 parents throughout the last couple weeks that I pretty much, they said, I went in and I demanded that they expanded my kid early. And the orthodontist said no. What kind of advice? What could we even tell? Like, why?
Well,
Why
what
doing
I
that?
what I say is that orthodontist should be you should shake his hand, pat him on the back, and say good job, because your ass shouldn't be fixing treating somebody because you don't understand it and you really don't think it's necessary. So at least you eliminate yourself as somebody who is competent and qualified and comfortable in providing this valuable service for this child. So you've eliminated yourself. You don't tell the parent that. I wish you would. Just say, look, I'm not qualified. I have 2 orthodontists that refer to me regularly now, and they do not want me to tell you who they are.
Mhm.
He said, I asked one of them, can I show this in my talk? He goes, as long as you take my name off the letterhead, because, I would be a pariah in my community. And this orthodontist sends kids from 3 hours away from Chicago to
Okay.
me. And he takes records and sends them. And he tells the parents, this is what Kevin does. I know he does it well. I've seen some of his results. I don't do this. I'm not comfortable doing this. And I don't want it to be part of my practice. I don't do restorative dentistry anymore. I
Mhm.
know how. I was good at it. I'm a board certified pediatric dentist, but I don't want to do it. And I've got other people in my practice that can do it, and there's not that big of a demand for it. So
So we
I
were
just say, yeah,
you
just,
respect the doc. So in a sense, so when they say that, it's like, okay, you know what? It's not your wheelhouse, and that's good. And so you're saying no.
yeah,
What do we do, or what do we say to some of, like, when we get into a position? So like down here, I'm in this area in Louisiana. There's nobody. I
yeah,
mean, I have to tell people to drive 3 hours. I got to go tell them to go different places. And what do you do if some people say, well, no, if no one's doing it around here, it's not important? Is it How important is fixing the structure early on? Like, what is the difference from
yeah.
fixing a 4-year-old to waiting to their 7th? Just to let people know,
Well,
like, how crucial of a difference.
a malocclusion is a disease, and I make the analogy to nearsightedness as a disease. And if a 4-year-old is nearsighted, would you say wait till they have more permanent teeth? Wait till their vision gets worse. Wait till they're driving a car. No, ophthalmologists, developmental ophthalmologists don't do that. They give them, because what is it going to do? It's going to get more complex and more severe. Well, what will malocclusion do? Transfers class 3 maxillary hypoplasia or mandibular retrognathia, all three of those. Mesocclusion, they call it, or distocclusion, and transverse deficiency with or without a crossbite. Those three phenotypes, 100% will always become more complex. I don't even say worsen. They will become more complex, difficult to treat, and either already are subtly a comorbidity with sleep breathing disorders. And sleep breathing disorders are often a comorbidity with neurological, neurobehavioral deficits, cardiac problems, hearing, conductive hearing problems. You can tie all these together and you can medically defend that with what's in the literature and what you are seeing in my practice, what you're seeing in Lauren Ballinger's practice, Laura Nahadas and Carla Damon's practice. There are so many people. Julie Davis in Chicago was one of our students. She's doing it right and left, taking care of these little kids. So no, you just it's a medically scientifically supported and medically defensible procedure. It's analogous to fixing what they call uncorrected refractive errors, which is farsightedness, nearsightedness, astigmatism, lazy eye. Those are all things that you got to fix those things when they're and you can't really cure nearsightedness. You can prevent it from getting worse. The cure is not there yet. Well, it's the same thing. We can actually cure malocclusion. We can, if we get in early enough, and if it's not, that severe, and you've got there's genetics to this as well.
Absolutely, yes.
We got a kid. Oh my God, I can't wait to show this. I wish you were coming to the ADA. That my partner treated from 5 years old, and he's 15 now. Never put a bracket on his teeth. We did 2 phases of ortho. We did a phase 1, part A, we call it, when the permanent teeth are within, they're not going to have 10 permanent teeth for another year and a half. That's part A. We only charge half our phase 1 fee.
And
And
what
then
what
when
are
they got that,
what kind of tools are
then
we talking about in that phase one?
expanders, fixed or removable expanders. Sometimes we do temporary braces on forefront teeth to consolidate, because you've got that in-bone crowding that Mariana Evans calls it, when you can see it on a Panorex. Or if
Okay.
you see lower crowding of any kind, 100% that means maxillary transverse deficiency. Lower incisor crowding, if they're primary or permanent, 100% it means it's maxillary transverse deficiency. And another reason to correct that isn't, what if there's no obvious airway problems? Well, prevent it from getting, Mariana Evans shows literature that it helps prevent age-related periodontal disease. If the teeth, what she says, if the incisors erupt into juicy bone, meaning
Uh-huh.
straight, you undo it. The in-bone crowding, you can uncrowd it while they're still in the alveolar bone. Okay? And then they come into healthy cancellous bone, and they're more resistant to the ultimate bone loss that happens as the face ages. It's going to be more resistant to age-related perio disease. So that's another reason that you want to relieve incisor crowding. I didn't know that. In fact, when she teaches a course and a lot of people are there, she goes, some of you are expecting me to say something about airway, but that's it. That's the last time I'm going to use the term for the weekend. and then she teaches this wonderful course. I really encourage it. And I'm
Yeah,
getting,
Mariana. I mean,
it's amazing.
there's, and then when you do that second phase, how,
Yes.
so talk us through just a little bit, just to give understanding, what does that second
Yeah.
phase look like?
Really important. So it's not really a second phase. I think you said phase 0, and that's when I thought, oh, I got to tell her about this. And we came up with this maybe 8, 9 years ago, and it's something that parents really, if you take them through it, manage their expectations, right? They know that this is something that, oh, he wants to make money, he's starting early. I don't charge my full phase 1 fee. If at least 8 to 10 permanent teeth are 18 to 24 months from being fully erupted, I don't charge my full fee. I charge half of my fee, and I call it phase 1 part A. And I usually get it done in about 12 to 18 months. And I don't need to see him that about every 8 to 10 weeks. I see him. And we optimize the transverse. We control the vertical and the sagittal, and we start to help correct it and move it forward. We do myofunctional therapy adjunctively. You know what a really simple form of myofunctional therapy is that any dentist or hygienist can
I was
do?
just gonna say, yeah,
Does
give
you,
us a good
yeah,
biohack.
does
I don't
your,
have
but by, yeah, good. Does your child chew celery, carrots, and apple slices, or do they suck the purees of them out of a pouch? Okay. And almost every parent will say, oh, we don't even use those pouches. Well, you're not with them all the time. Okay. So there's an article in the LA Times that teenagers are eating baby food. Baby food is the worst thing that happened to mankind. But
Well,
it
I
was
think
meant
also,
to,
just a real quick, just to go on the baby food aspect,
yeah,
people assume that if it's well, I don't give pouches. Okay, yeah, but your kid eats, you mainly do smoothies, pliables, all of these
yeah.
frozen versions
I
of
don't
the.
like smoothies. Smoothies wreck the fiber. That's wrecked fiber. If they have a smoothie and eat a full apple or chew some carrots or celery, go ahead.
Mhm.
Have your smoothie and rinse with water afterwards. But the fiber is destroyed. In Rod Lustig talks about that. Is that
Yeah, but a lot of
smoothies?
people,
Just
it's it,
yeah,
it's also this big thing is like someone goes, well, this is not a black or white conversation, right? Like I always say, it's like these pendulums, kind of goes ebbs and flows. Like people will say, oh, I asked people if they mouth breathe and they said no. I said, you can't ask something. It's not a yes or no.
yeah,
It's, you
yeah.
know, I said, it's like, you know, in this perfect world, you're supposed to be breathing through your nose, 90% of the time during growth and development. How much is that happening? And I think ultimately a lot of people just assume that it's all or nothing or anything, and there's so much of this gray area that people need to pay more attention to. And I think the food, we I always say, how much of your diet is hard, crunchy, and got like you're literally sinking your teeth into it, or half of the other one could just suck it down because you're a fast eater and you're not even sitting with your food. Most people won't, during after a consult, they'll come back 2 weeks later and they'll go, I didn't even realize I was eating so fast or that I was inhaling my food.
How do you think this is going to go over, Melissa? Because I'd like your advice, actually. And when I say to a parent, and again, I got evidence for this, it's okay for a kid to be a little hungry sometimes. It's a stress. It's a form like developing a muscle, and it really does, according to Sinclair, who wrote the book on longevity. It's a really great book. Is that there are genes associated that are being identified with longevity of slowing down the pace of aging, starting in childhood. Being a little bit hungry is a good form of stress. We're built that way. We're hardwired for it. We were always hungry. When is the next apple orchard ripen? When is the next buffalo herd killed? When are we going to scavenge, something that a lion is done eating? It just, a little bit of stress is not a bad thing.
Mm.
Okay. And being a little bit hungry. The Okinawa diet. Okinawa is a Japan island. They have
Yep.
this phrase: stop
Blue
eating
zone,
when you're
right? It's a blue
80% full, the blue zone. But the children in their schools, they eat like 20 or 30% less than people on mainland Japan eat. It's just part of their culture. It's just a low level of healthy stress. It should be. But
Well,
oxidative, that's
I don't
toxic. That's
I
toxic.
don't think it's that shocking because we know how good intermittent fasting is. We know, I mean, after you do a day fast, 2 days fast, every religion has a
Well,
fast aspect to
yeah,
it.
I'm not suggesting that for kids though. I'm just saying it's okay for them to be a little bit hungry.
Well, no,
And,
I was just saying in a sense, we know that there is
yeah.
positive of not being a glutton at all the time and constantly having the body. I think we over right. We don't have we have an overeating issue in the U.S. Do we not?
Well, how about breaking this to a parent of a 4-year-old? I'm going to start talking about Alzheimer's. I mean, so what? We're right now. We know there's data to support that these little kids that you are dealing with the myofunctional disorders, and together I'm dealing with the structure of the craniofacial respiratory complex and optimizing it. Well, better sleep and better breathing there's so much just about maxillary expansion alone, whether it's from myofunctional therapy or from maxillary expansion, that improves quality of life. There are 5 major papers that they're not huge prospective trials or anything like that, but valid QOL is a validated metric. Okay, you can measure it. Barry Raphael, he does it on every single patient.
Hmm.
And so if you are improving QOL, and another study, the Dunedin longitudinal cohort, I've told you about that
Hmm.
before, in Dunedin, New
Yep.
Zealand, 1,037 babies born in the same hospital in 1973 and 74 are still, over 1,000 of them are still being followed in 2025. Okay. You know what they found out, Melissa? That the
What?
kids who could demonstrate good quality of life and impulse control before the age of 12, guess what? They
What?
have less chronic disease between 35 and 40 years old, less chronic disease. They manage wealth better. They have less criminal behavior, less addictive behavior, and facial aging. They look 10 years younger.
Younger.
And
Wow.
this is all in the literature. And there's a new study just came out from the British Journal of Psychiatry. Children who don't have good impulse control after age 12,
Hmm.
okay, meaning that they still have ADD from childhood, do not have as long a lifespan. That cuts their lifespan back. So here's what I got to do is tell parents I'm going to do all I can to help slow down your child's rate of aging, okay, minimize oxidative stress, and help them sleep by helping them sleep and optimize their weight, healthy weight, all these things. I'm going to do all that. And then I say, but so what? I help them live to be 100 and they're still going to get senescence and they're still going to get dementia. I want to work on understanding and studying that. How do we slow down oxidative stress turning, senescent cells into amyloid beta plaques? Because every child has two 21st chromosomes, not three. They don't have a syndrome, but they're still making amyloid precursor protein. We don't know where that's going. You've heard of telomeres,
Hmm.
telomere shortening,
Yeah.
telomere length. You can measure that on little kids now.
Explain
You
that just for
can
just give a little index of that for people that don't know
Okay,
exactly.
if you take a shoelace, okay, here's my shoelace, right? See what's at the end, this little plastic cap? Okay, you imagine a strand of
Hmm.
DNA. Okay, well, there are nucleic, bases at the end of that. There's like, I don't know, there's a given number, and they know the exact sequence of them. They protect every time the cell divides until it hits that Hayflick limit, right? They shorten, okay? And the older you get, the shorter your telomeres get. But they protect all the coding DNA and all the junk DNA and everything else that we don't understand below it. That thing is just there. It doesn't code for anything. It's protective. But people under oxidative stress, even little kids, you can measure their telomeres are getting shorter, like old people do. It's reversible. Okay, so these are things that I want to bring into the dental world. I want this to be part of conversations, and I right now I'm controversial enough because I really get heights and weights on everybody, and
Yeah.
I let parents here go to the CDC website. You figure it out. I don't point out kids who are overweight or anything like that. I just give it to. I have the forms. Anyone who wants it, I have this handout. I'll share it with you, and you can give it to your audience. Everybody should be getting heights and weights. You should be doing it too, Melissa, if you're not. And let the parents figure it out. There's a BMI calculator for children on the CDC website. So anyway, I'm controversial enough because I'm doing that, but now I'm going to start talking about aging in
Well,
3-year-olds
but
and,
I think
and, and
it's
Alzheimer's. I like, oh my God, how do I do this?
well, with that, I think to kind of come to a little bit of full circle, the where I wanted to go a little bit on this was I wanted to talk about this, like, kind of this balancing, this biohacking, which really does come into people. And there is a huge movement, Kevin, Dr. Kevin, there's huge. There is a movement of people that are spending obscene amount of money on anti-aging, working on getting themselves to work better. And
Right.
I'm going to say something that I actually think I try to close all of my lectures of, if you're overwhelmed today, try not to get too overwhelmed. And I want to tell all the listeners that if you feel like, oh my God, I don't even know where to start, because I say where we were 15 years ago to where we are today is night and day. We're on the right movement, right? You have to have some patience here. But I think where we are at least in an era right now where people are starting to wake up. I feel like people are coming out of a little bit of a haze, right? Like we were in the era of everything fast, processed, this, quick that, plastic surgery, this, that, right? I call it the Miami Vice era, the 80s and 90s. And I'm going to say something probably that's going to upset orthodontists too, right? The way ortho was done in the 80s and 90s was, everybody just needed to have this picket fence style alignment. They only cared about getting the teeth lined up, and they were selling ortho like nobody's business, right? Turn and burn, turn and burn. And the truth is, I really do see we are heading into a movement where people, and I really encourage everybody this, ask why. Why are my kids' teeth straight? Why am I fighting this thing? Why do I feel this way? Why? Don't just tell me what you can do to, fix the, band-aid it, but I want to know why. Walk into the ENT and ask why and demand an answer. With that, I think we are going to see parents advocate. I think we're already seeing it. And I think, like, if you and I were to be talking to a group of doctors, I want to say to them, like, you have the ability to be in the forefront of this. This doesn't have to happen to you. This can be part of a movement. Like, you can claim that, take back being a doctor and start healing people. Like, if you and I could sit in front of a bunch of pediatric dentists, I go, do you know what a gift you have? You get to see every kiddo and look at them and treat their whole little bodies. And you can educate parents. You get so much time. And I kind of almost feel like this, where you're talking about what we're talking about, is like, this is like the little kid biohacking movement. We're going to talk about anti-aging for 3-year-olds, better food, get them moving, and truly put all these little kiddos so they can grow to be great adults. And I think it's about balance. And I think if we can work together and continue to do these things, I think there's a lot of positive. And I think the things you're doing, I don't know if what I'm saying is resonating, but that's what I feel like. I feel like we are in this good space. And from where you started to now, would you say that there's a lot of positive in the change? Like, do you see some of that?
Maybe not enough. I mean, I'm still so frustrated. I think it should be growing. I think it is, but and hearing that doctor from Atlanta, who, my God, he's taken my courses and other people's courses, and he just, I can't take the plunge, and I want to figure that out. Like, what can I do? Um, I don't know, Melissa. I know now this is going to be part of every conversation. I know that I know for sure, but I've accumulated empirical experiences. I've seen it, and the way my staff, they hear it from so many different parents that, oh my God, he's sleeping better, because we do that about every second or third visit. We update the pediatric sleep questionnaire, and you know sometimes it takes longer than others, and I tell people that it might take a little longer, but the secular trend is, the term we use is that you can be optimistic. Things are going to change for the better. But I'm never going to promise. I'm a dentist, and I'm going to do dentistry in such a way that it will be conducive to that. But there's other things that can be contributing to your kids' problems. The malocclusion is not going to go away. I mean, I'm going to fix that, you know. But I don't know. It's still it's not happening fast enough. I don't know. There's going to be a tipping point. Penicillin. I call this penicillin.
Okay.
What we're doing is like penicillin. That was discovered in the 20s, and it was a fungus, and then they change the molecular structure. That's how the pharmaceutical company, they can't patent things that are in nature. Did you know that? Like,
Yeah. Oh, I
so
know that from the psychedelic movement.
well, I was like, there's something called French lilac. That's what metformin is, and it metformin, the drug they use for lowering blood sugar,
Yeah.
that actually now they're finding out it does something to slow down the aging process. I mean, there's good science on it. This guy named Sinclair, Google him. He wrote this book. He's Australian. He's not a MD. He's a PhD at Harvard. But this book is so good. I've learned so much from it. So I don't know. I'm really all for getting more people qualified and trained and confident, and really to be able to defend themselves. I always tell parents, you're going to have to defend yourself. Maybe Uncle Harry at Thanksgiving's an orthodontist who thinks I'm a quack.
Mhm.
Here I go over. I spend so much. I learned today on the Luke's podcast. He said that the average amount of time that an orthodontist spends with a patient in
Ah,
consultation is under
it's
5 minutes, sometimes in a matter of seconds.
wonderful.
I, I spend
No,
45
that's
minutes to an
why.
hour, yeah, and I help them defend themselves. First, to themselves to spend the money, and second of all, to their
Mhm.
neighbors and relatives who think they're full of it because they didn't get braces till they were 13. You have to teach people, you have to arm them with
Yeah,
good
and you have to.
knowledge.
But that goes to just confirm one aspect, and I mean, and this will be a whole other podcast on its own, but that's been one of the areas I've been speaking about so much, is that because I was in that area of the business of ortho and the business of dentistry so long, you have to educate the staff, because I do not think we have a chance of actually continuing to tip the scale or move it if we don't at least try to support the people that are really making these systems. When I think say systems, these engines in dental offices actually run, because dentists or the orthodontists, they're not in there that long, right? They have a
Yep.
model and they go in, they got to
Mhm.
do it. You have to train their team, and unless and a lot of these treatment coordinators, and that's actually what I talked about on his podcast. I went to hygiene school and came back out, and my buddy was like, "I want you to stay my treatment coordinator." That's how I became the director of his practice. He goes, "You're way better at educating and selling than I goes, I can find somebody else to clean teeth." And the truth is, it was true. I had a power of educating, and that's what it's about. Storytelling, it's about making people feel something, and it's connecting that dot. And I think what you're doing, the things that we're about to embark with this study and getting the right people on the team, I know it's frustrating and I know it's been slow, but I'm pretty positive we're going to see some big changes in the next couple years, and I'm so confident, and I just have to stay in that conviction. I got to
You are,
stay in
yes.
that. And I know that I believe big things in the universe. You ask, you shall receive. And people want to help each other, I think, deep down inside. We just need to show them how. And we got to show them a way.
What you're do what I just told you, I like to empower parents, mostly female adult caregivers, that by giving them knowledge. You're doing that to me right now. You're inspiring me, and I know and it's contagious. I mean, my staff, they're hearing it all the time that the kids, and I don't know, I try to be a good boss and to work for, but there's such enthusiasm amongst my staff,
Yeah.
and my place runs like you're going to see. They keep it organized, and it's like it's fast paced, but
But
um,
that's what
I don't
drives you.
know.
And without that
Yeah,
team and getting to know you, and
yeah.
I think to just honor these other dentists and we'll give them some grace, and we'll say, most providers are only, I don't care, even providers, any business, you're only as good as your team. And the problem is that most the problem is, Dr. Kevin, these docs come to our courses and they come alone. And when they come alone, then they go back to their office. And I'll be honest, I've been that staff member that goes, oh God, he went to another conference and now I got to take his idea and try to make it work. He's not going to pay, or she's not going to pay anymore. And did it, bup, 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 bup. And then out of sight, out of mind. And then the doctor just walks away, and it's the truth.
No,
And
but that's just, he's not going to pay anymore. I love that
it's the
line.
truth.
I mean,
And then
it's like,
we took a crazy
uh,
poll just on
uh,
dental assistants. The
it's
average
hilarious.
dental assistant
Uh,
thinks, no joke, ready? How
yeah,
much money
yeah,
do you think the average dental assistant thinks their boss takes home in their pocket? Just ballpark.
yeah, yeah. I know. I don't even want
They,
to go
yeah,
there. Yeah.
$1 million. They all think every dentist makes $1 million. And and we'll wrap things up, but I made a joke to the team, right? I said,
Yeah.
to this one team, I said, I promise you, your dentist is not making $1 million, like take home
Yeah.
$1 million, right? And they
Yeah.
said, well, they make so much money. But a lot of people don't realize the business of dentistry is expensive. Dentistry overhead is very high. A lot of people don't recognize that. It's a small business. And a lot of these docs, no offense to them, they're trying to be practitioners, they're trying to be bosses, leaders, entrepreneurs. So I love the idea of trying to create power in building teams. And I think that is an area where we can all do better of talking more about supporting the full infrastructure of the business, because that will help us roll out better ways of being able to get our missions out. And it's just one part of it. So I I think the things we're about to do and where we're going, I'm excited for some of that, and I, I look I look forward for the future. But just so I can't thank you enough for being on today and allowing us to just talk. And I hope you
Oh,
come back.
I'm, if I was a cat, I'd be purring right now. This is like really, this has been so fun.
Tell me, if I was to see you at the end of this thing, just a little bit of inspiration and positivity. What kind of, like, what are you most proud about in your work? Just like a leaving thing. Like what if you think of your legacy, what is something that just truly brings you joy that you're so
I,
proud of?
the people like you want to hear it, and you're a people. I feel so useful, Melissa. I've never felt
Hmm.
more useful in my profession. And it's like saying I've never enjoyed being a dentist as much as I do now, because I don't do dentistry anymore. I mean, it's just like I mean, I don't do restorative dentistry, and I sort of made myself like that because I mean, I worked all my life to get there. My dad was a dentist, and that was before there were a lot of pedodontists, and he saw a lot of kids, and I just thought I idolized him for that.
Oh,
Um, my friends would, oh, your dad's so cool, and it's like, okay, I want people to talk to me about me that way. Instead, sorry, I have to give injections and do pulpotomies, and it's like, oh, this ain't what I thought it was. Uh, and I know, because of my background in nutrition, I understand. And then now, this is before I understood anthropology, is that tooth decay is 100% preventable. So
hmm.
I'm making my living, you know, and then you brought up religion. I mean, I sort of, I can see why orthodontists don't want to radically. Barry almost had to see a shrink when he
Hmm.
first discovered that his work, he was causing harm. And what I say is, when you're trained a certain way and you come out, and like you were saying at LSU, everyone's got the same curriculum for generations, is that if you really won't allow yourself to change your mind, because and I say it's like a clergyman, like a minister. I grew up influenced by Congregationalists and Unitarians and stuff, and so a Protestant. But it's like a Protestant minister turning into an atheist. What is he going to preach about on Sunday anymore? You know, because he and I just, luckily, things happened with me very gradually. Is that I I could afford to allow myself to be disgusted with
Mm,
making a living on a disease that I know is 100% preventable because I did my
mhm.
master's degree in tooth decay and obesity. Go figure. My mentor, Rachel Schemmel at Michigan State, she was studying obesity, type 2 diabetes, and tooth decay. Can you imagine that? She knew about the carbohydrate connection. It was amazing. Yeah,
I believe
yeah,
there's no coincidences, and I think you're
yeah,
exactly, if I where I get to get this beautiful is that I believe that everybody is put on this earth to do exactly what they're supposed to do, and I am so grateful and so honored that you chose and continue every day to push the envelope and keep making people think different and constantly bring up new topics. It's truly inspirational, and I cannot thank you enough. And with that being said, I cannot wait to have you back on. Maybe after we get more moving and grooving on this, on some
yeah.
different research, we can kind of let people know where things lie. And yeah, our goal together is let's keep moving this train forward, and let's try to really help docs maybe keep clearing out the cobwebs in their eyes or the little sleepies. Get
Yeah,
them
yeah.
to start seeing things differently.
I welcome any and all from your listenership. Like he's full of shit, or that's garbage, you know, um, or if you want literature to support anything I said, I'll send you PDFs of papers, and I'm interested if people want to have conversations. Give them my email address. Um, I'm only working
I was
three
just going to
days
say,
a
yeah.
month, so
How would we like everybody to get a hold of you, or what do you want them to follow you on, or what do
ju-
you want them to
just
keep an eye on?
just my email address. I don't I don't do a podcast. I don't. I'm someday maybe going to write a book with maybe you and Sharon Moore. I just but I don't know. Just my email, uh,
Okay, we'll get
and
your email
I'll
out, and
send that.
I'll we'll let everybody know. Maybe we'll do some webinars and get some people to be able to do some live questions. It'd be fun to maybe get some people to come on and do a live Q&A of just getting interactive. Uh, I love hold a good little meeting where people can ask, and we get to ask in real time and answer questions.
Yeah, Melissa, you're on fire. I mean, this is
Thank you
like
so much.
so contagious. I'm there's more of us. We have to continue to do this.
Until next time, guys.